Wonderful. Well, it is certainly great to have you all here. My name is Emma Holmes, and I'll be moderating our wonderful panel. I'm a certified orthotist at the PBO group in Kitchener, Ontario, and chair of the National Orthotics and Prosthetics Day Committee with OPC. Today's panel is part of our celebration of National Orthotics and Prosthetics Day, happening this Friday, September 19th. This year's theme, We Are Orthotics and Prosthetics, reminds us that achieving quality patient outcomes isn't something we do alone. It takes collaboration across disciplines, engaged patients, and supportive families. And that's exactly what we're here to talk about today. We know that what collaboration looks like can be complicated by complex patient needs, funding, geography, changing care models. Despite these complexities, we hope today's panelists can showcase the possibilities and opportunities when we work together. We are joined by a fantastic group of panelists representing orthotics and prosthetics, physiotherapy, and podiatry. Each brings unique expertise in preventing wounds, protecting vulnerable limbs, and caring for patients with diabetes. You'll hear personal stories about what they've learned on the front lines and moments when collaboration changed the patient's trajectory. As you listen, I invite you to reflect on how you might apply these insights into your own practice and when you can engage more closely with your allied healthcare team to improve outcomes. Diabetes is one of the fastest growing healthcare concerns globally, a leading cause of lower limb loss, and up to 85% of diabetic-related amputations are preceded by a diabetic foot wound. As more people live with complex diabetes-related conditions, team-based care will be more important than ever. While we won't have time to get into too many specific details, this panel is designed to give you practical insights into offloading strategies, assessment techniques, and collaborative care models that help prevent serious complications and save limbs and lives. Our panel discussion today will be followed by a Q&A period. I encourage you to use the Q&A message board at the bottom of your screen throughout our discussion to post your questions. With that, let's get started and meet our panelists. First, we have Holly Houston. Holly is a registered orthotic and prosthetic technician at AR Menzies in Fredericton, New Brunswick, with 19 years of experience in facilities across Canada. A graduate of George Brown College, she is taught in its technical program, serves as the director on the OPC board, and volunteers with the technical registration examinations in multiple OPC committees. Dr. Caroline Leverett. She's a registered podiatrist with over 25 years of clinical expertise, specializing in diabetic and chronic disease pathologies affecting the lower limb. She manages her own rural practice and leads a multidisciplinary foot care team and is deeply engaged in advancing podiatry through education, research, and policy. Dr. Leverett serves on the executive board of the Canadian Podiatric Medical Association and is president-elect of the Nova Scotia Podiatry Association. Lynn Clark. Lynn is a physiotherapist at the Health Science Center in Winnipeg, where she has worked for more than 30 years in surgical, orthopedic, and rehabilitation care. For the past 7 years, she has specialized in orthopedic technology, undertaking specialized training and expert mentorship to provide total contact casting and education to clients with diabetic foot conditions. Lynn works closely with orthotists, physicians, and families to support recovery, promote prevention, and improve long-term outcomes. Alan Blythe. Alan Blythe is a certified prosthetist orthotist based in Kelowna and Castlegar, British Columbia, a past president of both the Canadian Board of Certification of Prosthetics and Orthotics and the Prosthetic and Orthotic Association of BC. He now serves as chair of the Partnership and Advocacy Committee at OPC. Alan actively represents the profession in provincial stakeholder discussions and was recently awarded his fellowship in recognition of his outstanding service and contributions to the field. And last but not least, John Raymond. John is a certified orthotist who has been in practice since 1984. He works in private practice and as part of interdisciplinary teams, including the Sheldon Schumer Wound Clinic in Calgary. John has presented nationally at Orthotics Prosthetics Canada and Wounds Canada conferences and contributes to clinical teaching and best practice guidelines in wound care, diabetic complications, and prevention strategies. Without further delay, panelists, we have a tremendous group here with us today. Let's get our discussion started. Thinking broadly about your collaborative practices, what are the biggest challenges you face when working with diabetic patients? And how does multidisciplinary collaboration and transdisciplinary care help?
So shall I? I'll start. For a podiatrist, the hardest thing is to know that everything comes all at once. So managing somebody who's that complex, they come in with a multitude of problems that need fixing right now. So the challenge is to know what to prioritize and who to ask for help. So knowing who's available and their scope of practice immediately is really handy because they're so complicated.
Due to the multifactorial and comorbidity side of most of these complex patients, having everybody on board at initial assessment is very important, including the diabetologist. Managing glycemic levels is a critical strategy in wound prevention and wound treatment, as well as having the physiotherapists, nurses, debridement staff, physicians involved in initial assessment at intake. And strategizing for the best outcome immediately is very important to the success of patients that come to us with diabetic foot wounds from the prevention and treatment side.
And I think for me, the biggest thing is, are you able to hear me?
Yeah.
Okay. The biggest thing is patient education, because when I see patients in the diabetic foot clinic, they often have been months and months dealing with an ulcer on their foot or having a Charcot foot that's been misdiagnosed. And some of them have never, ever been told in their diabetic journey that they need to check their feet daily, that they need to monitor for wounds, signs of infection or fractures. So the biggest thing is just education, education, education.
I would concur with that. And, you know, they come to us with some serious health issues, deconditioning. And there's also some lifestyle changes that we need to encourage with this patient population as well, in a very respectful and kind way. But at the same time, the thing about collaboration too is that you get common messaging if everybody's saying the same thing to these patients. So I think that's a really important part that you raised there, Lynn.
I think those are all some great points made about the need for triaging in terms of urgency, collaboration right off the get-go in that early assessment. I was wondering what, we know that collaboration will look different. We all come from different practices, a pretty amazing group in the fact that some of us are even on the East Coast, West Coast, rural and urban. With that in mind, are there any simple strategies that individual clinics can implement to improve collaboration dependent on, individual clients or clinics or multidisciplinary settings?
In Alberta, we routinely use telehealth methodology to be able to assess rural clients using some of the benefits of the multidisciplinary team through a telehealth presentation with rural wound clinics. When we did our presentation to the wound care teams, home care teams in January with Linda Lasco Amesbury, we had 25 rural clinics on a Zoom meeting just like this to be able to enhance their knowledge of what we can do, how we can provide treatment, and how we can collaborate without all physically being in the same space.
And what did that lead to, John?
It leads to having a diversity of opinion when that patient is being presented to the telehealth team, and improves immediate triage of that patient for whatever their needs may be, whether it's vascular surgery, antibiotic therapy, offloading. It's to have that many people at the table immediately certainly prioritizes, as suggested in the previous answer, the needs of the immediate patient care first, and then the long-term strategy secondarily.
That's a really interesting approach set up. So when you first started talking about it, I kind of assumed it was more of a presentation style to get everyone kind of familiarized with approaches, but it really is a more immediate kind of telehealth opportunity, or quite current in terms of active treatment going on, decision making needs to occur when you're reviewing these patient cases.
Absolutely. It's literally, there will be a predestined time for the meeting to occur. There will be 3 or 4 people around the telemedia facility. The patient will be presented from a rural facility on a Zoom call, much like this, a little bit of a different format in telehealth, much more privacy, walls, and etc. But there will be a visual presentation, there will be a clinical history, and strategies will be implemented almost immediately during that telehealth call.
Certainly in the hospital I work in, we treat a very large area. Patients from Nunavut, Northwestern Ontario, all come to Winnipeg for treatment. And it's very nice in our adult orthopedic clinic and diabetic foot clinic. We have sometimes immediate, but usually very timely access to the orthopedic surgeon, the infectious disease doctor, the vascular surgeon, and home care nurses, foot care nurses, and then the orthopedic technologists for casting if required. And we also have in-house orthotists, and out of the center orthotists come in as well to see the patients right during assessment and treatment.
And what does their stay look like when these fly-in patients attend clinic, and then I assume stick around in some occasions?
It really depends. The standards is if they have an appointment again within another week, they are kept in the city, housed somewhere. And then if their follow-up isn't for 2 to 3 weeks, then they fly back to their home community and to return again.
And is there any telehealth in the interim?
I don't think they're doing any telehealth for these clinics, not that I know of.
Caroline, you're another very rural located independent clinic owner, and you work with a multidisciplinary team within a rural-ish setting.
Yes, certainly it is. And certainly in parts of Nova Scotia, telehealth is coming. I would say that for the majority of patients who live in the city, that becomes less of an issue. For the minority of population in Nova Scotia that live rurally, it is a problem. So somewhere like Cape Breton, telehealth is coming, but it's limited. And certainly here, where I have my clinic, it doesn't exist at all. So it's all about knowing who you can contact in a timely way. So just knowing names, knowing faces, knowing phone numbers and email, and that really is as basic as it gets.
How did you build those connections initially?
You just get out and go out and meet people.
Mm.
It's very low tech. You just have
Yeah.
to go and meet
Shared
people.
interests, no doubt.
Attend conferences, shared interests, just go around and annoy them.
It's great to hear about the the different multidisciplinary approaches all three of you shared, and various strategies for implementing them. Regarding treatment approaches, you all work with diabetic patients, providing limb care on a probably almost daily basis. You each bring unique skill sets to the team. What treatment strategies do you think have been most effective in treating foot wounds and ulcers in your experience?
I'm a part of the Sheldon Schumer Foot and Wound Clinic team, and we routinely use a variety of offloading approaches. We were very lucky in 1997, the government came to us with a budget for a pilot program that allowed us to do removable cast walkers initially. That was it. Eventually, it expanded to using the adapted Darco wound care shoe system with a total contact insert that allows us to directly offload the site of the wound. And of course, we use total contact casts. Or we worked that pilot program for 2 years. Our data was submitted to the provincial government, and it was immediately instituted as a benefit for anybody with diabetes and neuropathy initially, and then expanded to diabetes, any form of neuropathy, and anyone with an ulcer related to a bony prominence or other disease like an autoimmune disease. Even cancer patients have been treated and allowed to be treated through the Alberta AIDS to Daily Living program.
So in some areas, of course, across Canada, we're more, as orthotists, more likely to use, custom devices. The ones you mentioned were what many would call off-the-shelf kind of devices, but you had success with these.
None of the items that I mentioned are exclusively off-the-shelf devices. When we do a removable cast walker, we must put in a total contact insert that has been relieved at the site of the wound. Instrumented testing shows that a removable cast walker alone is only capable of diminishing ground reaction pressure by about 5% at the site of the first metatarsal head, the fifth metatarsal head, or the hallux. With a total contact insert, we can remove 70 to 80% of ground reaction pressure back against the site of the wound, because of the implementation of a relieved total contact insert that is applied directly to the foot and then fitted within that off-the-shelf device. So it's a combination of an off-the-shelf device and a custom application. And that's very important.
So what we do in podiatry is primarily debride lesions. That's where our skill really lies. So we will debride everything that's appropriate. And then in the very short term, while you've got the patient sitting in front of you, we can offload them immediately with a disposable semi-compressed felt, which allows you to target offloading wounds in the very, very short term. So you get your arts and crafts moment to just make something really creative and just get that wound offloaded straight away. And then even if you need to just do it for a day or two, so that can be removed and then something more permanent made, it just buys you time to get that wound offloaded immediately before they can see somebody else with the greater technology and the skill. So, but debriding all that crud off a wound is absolutely the key.
And that's what we've found in our clinic is our orthopedic technologists and me and the wound care nurses are all trained in conservative sharp wound debridement, removing all the non-viable tissue. And we're doing that between every total contact cast change. And we're finding very good success if the patients can also completely offload by using a knee scooter or wheelchair. Many of our patients are frequent return customers. We've had people in as little as a week coming back with an open ulcer after coming out of total contact casting. And that's even with an orthotic graduating into a diabetic offloader shoe or in a boot. And it's very frustrating. They do heal in a total contact cast, and unfortunately, they sometimes break down again very quickly because that new skin is so delicate. So it's frustrating for the patient. It's frustrating for the clinicians because it takes months sometimes to heal and such a short time to break down. And our orthotists are experimenting with, do they put the orthotic in a boot before putting it also in a shoe? Do we do a few hours at a time only to gradually get used to the orthotic? Yeah, it's very, very frustrating for both the patient and the clinicians.
John, I feel like I could see your wheels turning on that one. Do you recognize some of those challenges that Lynn's brought up, or what are your thoughts?
In our setting at the Sheldon Schumer and in Calgary, our protocol, whether it's post total contact cast or post offloading device, when a wound is considered healed, it is not considered ready to transition to a shoe for at least 4 weeks. And 4 weeks is our minimum. And that is in order to reduce the risk of having a re-breakdown of that wound. This involves, if we are transitioning someone out of a total contact cast, they must go into an offloading device. And if they go into an offloading device as opposed to a total contact cast, it's very easy. We just leave them in the offloading device. If they're in a combination of an offloading device and a knee scooter, we initialize them not using the knee scooter for moving around their house. And we insist on self-monitoring by the patient. And it's very easy to do. A simple foot mirror, a little mirror that you place on the floor in a safe place in your house, take off your offloading device, look at the wound, any concerns, and it's back to the multidisciplinary foot and wound clinic.
Fantastic. I knew we were going to have a lot of discussion about that. Thank you for all sharing your insight. We've begun to talk a little bit about the characteristics that might drive selection. Certainly just talked about thoughts around progression between devices and the rate of progression and based on time, healing, and where they're moving from total contact cast to something else, etc. How do you each approach assessment individually or with your multidisciplinary teams of these individuals? And what would you consider essential in an assessment?
I'm happy to jump in on that. In the Sheldon Schumer setting and the Zivit Limb Preservation Clinic setting, an initial assessment of a referred patient will involve probably an hour and a half of time. It will include vascular studies that include ABIs and toe pressures, visual analysis, assessment of loss of protective sensation, glycemic indexes, including A1C, so we can see what that patient's been like over at least the last 3 months. We do have immediate access to all of their online charts. All of those will be reviewed. We will have a physician, NSWOC nurse, nurse, physiotherapist, occupational therapist, and typically, if they know there's going to be offloading device necessity, I'll be included as the certified orthotist at that initial intake exam. Anybody else?
Yeah, so we'll that initial assessment, we'll review, take an entire history. So a podiatrist is trained to assess, diagnose, and manage. So we'll do a full history, and that will include socio and economic status, as well as the vascular, medical, surgical history, and then depending on what they're presenting with, we'll debride any hyperkeratosis, provide any wound management, prescribe medication, perhaps including an antibiotic or whatever else is required, request x-rays, and then take swabs or refer on. So obviously we're doing a full vascular and neurological assessment as part of that. But the referral then depends on your scope of practice. So if you're a surgical podiatrist, you might decide that you're going to do an appropriate surgery, whether it's removal of a joint or part of a foot. But it depends. It very much depends on scope of practice, and across Canada, that with podiatry that varies hugely. So you'll have everything from a postgraduate diploma in Ontario to a podiatrist and surgical residency on the West Coast. So it just depends where you are. But overall, your podiatrist is going to provide a fairly thorough basis and then know where to put them next.
Alan, you work in a prosthetic orthotic clinic, providing care to both limbs. I'd be interested in your perspective on this.
Well, initial assessments, you know, for prosthesis would also include a full assessment of the contralateral limb, strength, range of motion, skin, sensation. You know, you would also take lifestyle, as Carolyn pointed out. You know, you're going to find out who they are, where they live, do they live independently. You're going to look at things like eyesight, cognition, hand strength for donning a prosthesis. Those are all things that I look at. So, you know, and then again, you know, with the contralateral limb, you know that they're likely insensate on that foot because peripheral neuropathy typically is bilateral. It's not unilateral. So, you know, you've got to take that into account. Very often that is going to necessitate a look at footwear, make sure that they're wearing correct shoes. And then you're going to look at those shoes and make sure that their foot, their sound side, use that in italics, it fits into that shoe appropriately. And very often, probably they'll need something either in the way of a custom foot orthosis if they don't have a wound, or they'll need something more appropriate for the wound if we're going to be doing some offloading.
Certainly, you can see how the scope of a multidisciplinary clinic really can help guide decision making. And then when you get down to the level that you're providing the care, those details that matter, and kind of further going into things like footwear and lifestyle.
Yeah, and absolutely. And you know, you look at how deconditioned they are, and very often they are deconditioned. And that's where referrals to physical therapists come in. And then, you know, when you ask about home environment, that's where referrals would maybe go over to occupational therapists if it hasn't been made already. And then wound management, you know, if it's something that you feel is beyond your scope, then you're going to be referring that over to a wound specialist.
Sure. That is our shout out for OT and more PT involvement in future discussion, because it certainly has a place to play here. Now we all have our unique skill sets and often do our best with the tools available to us. What are some red flags that should trigger a referral between professionals?
I have an excellent example of that. Last Thursday, I was referred a patient by our colleague, Paul Osborne, who most people here know, for assessment of his contralateral limb. Paul is a certified prosthetist. When the patient presented, he was talking about the pain that he was having when he was getting in and out of his truck, and he still, in fact, drives big rigs for a living. When I got a hold of the foot, I noticed immediately that it was odoriferous. The foot presented with a rather large gangrenous wound on the 4th and 5th metatarsal heads, of which I can show you a picture if you can see it. And I immediately contacted the vascular team at the Zivit Limb Preservation Clinic, who contacted the emergency room. We expedited his triage through emergency. That was on Thursday. He had surgery on Friday, had the 5th metatarsal head removed, and is at home convalescing today. He phoned our clinic to thank us for getting him in for that immediate assessment and treatment. He was at risk of losing that limb and becoming a bilateral amputee.
Impressive.
Yeah, certainly a huge turning point, which could have gone down a different path. And that one is quite, you know, progressed and and dangerous at that point. We all certainly also come across things that are more insidious, maybe less obvious, between orthotics and podiatry. Either way, going from podiatry to orthotics or orthotics back, are there things that maybe are less obvious that needs to change path? You know, those times where we should maybe not wait and see.
Absolutely. So anything really, the rule is anything that is out of our scope of practice needs to be passed on. You need to recognize that you can't do everything, and not one person is going to be able to have all the answers. So that's a bit of self-humility is really important. But also anything that is changing. So if it's changing slowly, you've got more time, but you have to be able to recognize that things are changing, and particularly when they're deteriorating. So if you're not actually looking and observing every time you see it and looking for change, you won't see it. So your red flag should be look for change, and particularly for deterioration. Things are improving, that's great, but that's not generally when you need to refer.
Another excellent example of a red flag would be a neuropathic patient with a painful foot. If they hurt, if they're swollen, if they have an elevated temperature, even if that foot does not suggest deformity, they need to be referred for diagnostic studies.
That's a good flag. Lynn, you were going to say something there?
Yes, so when we have patients come in to see us, we first remove their total contact cast, and the physician needs the foot untouched and just open to air, and he always has both feet exposed to check the temperature every time between casting, and he's looking for that less than 2 degrees Celsius difference between each. But even if we have patients who have been followed for a long time, checking both feet is critical, because often the one that's being offloaded will very quickly cause problems in the contralateral foot. We've diagnosed Charcot foot starting in the other limb, which then needs to be x-rayed and carried through. And also small ulcers. The patient is so focused on the affected foot that often things have started to deteriorate on the other foot while they are offloading the foot with the wound and the cast.
And I think that holds true in prosthetics as well. No matter how great a job we do as prosthetists, the patient will always defer to the other side to put the bulk of their weight on it. You can see that when they're first starting out in in a prosthesis, they stand there and you can see that their upper body is shifted over to the contralateral limb. So that's where that becomes a real issue, because you know that that foot is not in great shape either when you're dealing with a diabetic population.
Yes, and certainly we really encourage patients, because their balance is off and they are putting so much more weight on the other foot. We're encouraging them to use a walker or at least a cane or crutches to help offload the foot even more. Using a knee scooter helps only the foot that you're kneeling on. It doesn't help the other foot, but certainly using a walker will significantly offload both feet. So when able, we try and encourage patients to use any gait aid to help.
Alan, do you have any specific advice for prosthetists that might be listening who do not have dual certification? Please
look at the other foot and do it on a regular basis. You know, at your initial assessment, you should monitor and look at the contralateral foot, identify any areas that may be problematic. If you think that there is going to be a problem, refer them to somebody who can look after that. Refer them to a colleague, either an orthotist, a podiatrist, somebody. And then while you're treating them, because we know that prosthetic care doesn't just happen once, it goes for months and months and months and years, constantly have regular routine follow-up on that foot and make sure that it is not going downhill. Make sure that it is staying intact.
That's right. Because what percentage would you say of individuals using prostheses are diabetic?
Oh, it's got to be over 80% right now.
So this is a very big conversation, really, for prosthetists.
In fact, diabetes is the leading cause of amputation in the Western world.
It is.
As an orthopedic technologist, we do a lot of education with medical students before they're even in their residency. And they have a casting session with us just to know the basics of what a cast is, how to apply. And we sort of quiz them, and they've often just finished their session on endocrinology. And surprisingly, I would say most of them had not heard of Charcot foot when they covered their endocrinology information. So it's really important at that basic family medicine level to educate our future doctors and to have that on their differential. If someone is diabetic, don't assume it's cellulitis. Do the X-ray, do the MRI, offload immediately. Yeah.
It's probably a worthy time then, Lynn, thank you, to plug the upcoming public education document that Orthotics Prosthetics Canada is in the process of publishing right now on early assessment of a potential Charcot foot. Its intentional distribution is to the family medicine and emergency room level. And I really appreciate your segue. Nicely done.
Thank you, John. Further segue. It will be available on our website, I'm sure, too. And there currently is one on use of crow boots or Charcot restraint orthotic walkers and other offloading orthotic tools used for this patient group, which has been a fantastic resource provided by kind of an expert group. All right, Holly, we'd be remiss to discuss offloading without your technical perspective, and we're glad to have your expertise. As a registered orthotic prosthetic technician, what do you do differently when building for diabetic users?
For us, a lot of it comes into play when we're dealing with total contact or offloading boots and on the orthotic side of things. It's super crucial to be aware of where the existing ulcers are. So clinicians marking that down and letting us know. So then we can be very precise with our placement of seams during the fabrication process. We don't want any uneven surfaces or irregularities that could cause new pressure points or further irritate the existing sores. And so having a plan before we get started definitely helps with this process to try and fine tune everything and to try and foresee any issues that may arise from the original design idea, because sometimes there's an idea that a clinician has, and making that actually come to life, it is a lot of back and forth between us.
Yeah, offloading is not easy and complicated limbs. And every limb is different. So unique challenges every time. When it comes to the material features, what should a healthcare provider, orthotist or other, consider when designing or providing these offloading devices to diabetic patients?
Yeah, I would say material science plays a pretty crucial role in the fabricating process. Being aware of like what's closed cell, what's open cell, what's abrasive, because that can cause obviously skin irritation or breakdown. And that happens more quickly with constant skin contact. So that might be something that you would want to like sandwich between layers of a softer material. How much the material is going to compress or pack out during the fabrication is also an important consideration, just to decide if we need to double up the thickness in that area. Understanding these properties allows for better preparation and more effective outcomes during the fabrication process. And it also depends on what the clinician is trying to accomplish. Are they trying to offload the entire limb or just a specific area? And usually what like the final outcome is, we're usually going for like smoothness and softness. Those are usually pretty important. And then also like a cleanliness aspect is pretty important too. So making sure that they're pretty easy to like wipe down and keep clean. It'll help with both hygiene and the overall longevity of the device.
Alan, I see you shaking your head yes to that. And John, yeah. We've already talked, I think, on side conversations about the importance of materials and the engagement with a technician, Holly talked about like clear markings, and some back and forth discussion. Why does this matter, that we engage with the technicians?
Oh, it's extremely important to get the outcome that we're looking for. A crow walker, for example, is a very expensive device. And it's not something that you want to remake because you didn't get it right the first time. We've been using material science, and as far as 28 years ago, we started using intuition foam for exactly the properties that Holly described. It's a closed cell foam. It's easy to clean. You can clean it with a Lysol wipe, kills all the bugs, and you can actually resurrect the softness of intuition foam with something as simple as a blow dryer. We use Spanko for a covering for our total contact inserts, specifically because it's got an extremely low coefficient of friction. Another point that Holly made very clearly was to reduce the abrasiveness of the contact material. And that's one of the reasons that our material selection has been so important. And my technician has been absolutely by my side for 28 years now, and he's an excellent contribution to our team.
And I would echo that. I think you made a really good point. Sometimes, we have ideas about what we can do, and the technician is the person who has to build it. And so they live in the reality of, well, is this possible? And so there needs to be a collaboration between the clinician and technician to make sure that they're both on the same page of what can be done and what can't be done. And then you get into the nitty-gritty of the fine details of, okay, what materials are we going to use? What alignment are we going to do in the case of a prosthesis when you're setting it up? Those are all things that need to be interacted between the two.
What kinds of like communication, what does this look like, kind of the ideal collaboration between clinician and technician along this pathway to dispensing advice?
For me, I would say like a combination of a few things, like having what I would call like a tech sheet. What is always like good information. You have something physical in front of you that you can always reference, but then being able to like have a face-to-face conversation with the clinician at the same time, like just to be able to like throw your ideas back and forth and it not take forever, like sending an email or whatever. And clinicians are obviously very busy, so having all of your questions prepared beforehand and then trying to get everything answered in like this initial kind of design phase that you're kind of trying to create.
Yeah, I agree with that. I mean, as orthotists and prosthetists, we do stuff that is all one-offs typically because it's custom made, especially, in prosthetics. When you're making the socket, it's all done to the individual over a cast. So it's really important that the technician and the clinician are on the same page and are in agreement about where they're going to go with things like where we're going to put the block underneath the socket, what material choices we're going to use for the for the prosthesis, etc.
Great. We've explored a lot about the technical aspects, collaboration now, assessment techniques. It's been fantastic. We just have a couple of closing questions before we get to our Q&A. In fact, I'd like to zoom out for a moment. We know anyone can become diabetic at any point. We've talked about education throughout this. What advice would you give someone who is newly diagnosed with diabetes?
Absolutely. The most important thing is to respect their blood sugar monitoring. Glycemic control is the most pivotal tool that a new diabetic has to be able to reduce the incidences of diabetic neuropathy. Secondarily, whether they have loss of protective sensation or not, education on the importance of skin health and foot health is absolutely fundamental. And at the early stages, it's extremely easy to do, provided that the patient's willing to buy in. I strongly suggest reviewing some of the work of Dr. David Armstrong. He's been published 1 million times for his work, and his strategies for the new diabetic are very, very simple. And when I meet a new diabetic, I give them the public education document that Orthotics Prosthetics Canada has published just as a tool for them to become familiar with the concept of the diabetic foot and be able to enhance their own strategies for maintaining their health during the period where they're getting used to the fact that they've become a diabetic.
That's great. Lynn, I know you do a lot of education. What do you have to say about this?
Well, it's very complicated because often our patients are smoking. They're coming from jobs where they are doing either manual labor or truck driving is very common, and they don't have social supports to take time to offload. So if we can prevent problems, I would say number one, of course, the blood sugars, but quitting smoking is critical. And then to start looking at their feet. I can't tell you how many patients we've seen who have never been told to get a mirror. These are patients who aren't able to inspect their feet themselves, and they may not have someone in their family who can inspect them. And they're just like, well, I can't see the bottom of my feet. And these are people who are not new to diabetes. These are people who are typically 5 to 10 years in minimum, and somehow they've never been told about foot care. And so I think the education at initial diagnosis, covering that foot care matters as much as worrying about their heart disease, kidney disease, and everything else that can come with the complications. They just aren't educated about the neuropathies and the importance of foot care.
So I would suggest that most family doctors, unless they have a particular interest in diabetes, most family doctors sort of know the basics. But I think having an annual review with a podiatrist or chiropodist would be kind of a minimum for those kind of really basic education tools like footwear advice, checking your feet daily, the vascular and the neurological annual assessment. Because if they're low risk, which you hope that they are when they're newly diagnosed, you hope that they haven't sat on this for years and developing complications before they're picked up. That even an annual visit, if that's all that is available or they can afford, that would be a really good start. There's all kinds of really good literature out there, whether it's provincial or federal, or even international. There are loads and loads of useful tools that we can use to educate patients. And then at least you screen them and you're kind of keeping an eye on them. If they've got access to email, they want to send you photographs if they're not sure, those kind of things, just to keep them in the loop. You don't have to see every newly diagnosed patient every 3 months. It's just about educating them so they can take responsibility for their own care and keep moving. Whatever else happens, they have to keep moving and increase that glucose uptake, reduce their insulin resistance. It's our job to keep them moving, however we do that, and whoever's best placed to do that.
We have glycemic control, quit smoking, observe feet, annual reviews with a podiatrist. I think those are fantastic 4 things to remember for prevention. Alan, what would your suggestions be for someone possibly that already has an amputation? What's kind of your messaging to them?
If they're a unilateral amputee, then they've really got to do everything they can to preserve the sound foot. In one of the ones I think that was missed was inspect footwear. That's the other thing too. Very often people will come in and they'll say, yeah, I didn't know I had a wound on my foot until I saw the blood behind the shoe. So check the footwear, because if they have peripheral neuropathy, they're not going to feel if they have a sliver or a rock or a nail inside the shoe. We pulled nails out of the bottom of people's shoes before and they didn't even know they were there.
Lego is my favorite.
Yes. So once they become a unilateral amputee, unfortunately, they're going to use more energy to walk, no matter how good a job a prosthetist does at supplying a prosthesis on the amputated side. They're still going to use more energy to walk because their center of mass is going to go outside that nice tight little box. So it really becomes about making sure that you're not putting the other foot at stress and the other side at stress. And that's where physical therapy and gait training can really come in. Gait aids, like Lynn mentioned, to offload. You know, and then it's really about educating the person. I think education is the key with this disease, is that, you know, no matter what stage they're at in that sequelae, education every time you see them, you know, and encourage them, you know, encourage them to stop smoking, encourage them to get more exercise, encourage them to be active.
I just want to interject for a second because I kept meaning to bring this up. One of the things I look at all the time when patients come in are their beautiful custom shoes and orthotics that are so clean and in perfect condition. And I think it's really important to inspect whether you think this device is being used, and then to point blank ask them, when do you use it? And many of the patients will say, I use it every time I go outside. And then I ask, well, I mean, you're not working, you're off work, you're at home. What do you wear indoors? They go, nothing. I walk around barefoot. And I don't know how that vital piece of information is missed, but the patients somehow don't think of wearing their orthotics indoors. And I think that's critical because most people spend most of the time on their feet in their house.
I agree.
I wholeheartedly agree.
Absolutely. Yeah.
It's unanimous. I hate to say we're pretty much at the end of this panel. I know we could go on for a long time on this topic. And there's some things we missed today, but thank you for this great discussion. To close, if you could each leave us with one practical takeaway about working collaboratively in diabetic limb care, what would it be? Where can we start, or how do we start to build better partnerships to make this possible?
I'd like to start by saying, if you're in a position where you don't have access to a multidisciplinary team and you're trying to build relationships, use Orthotics Prosthetics Canada's resources to begin to build your bridges. Use the public education documents that we have available and send them to your referral sources. Open the door to communication. Be willing to have discussions. And if necessary, and we do this frequently, be willing to do an in-service for the people that you're intimately involved with, to give them a little bit more direct understanding of what the capabilities of the multidisciplinary team are, or your singular component of the multidisciplinary team.
That's great. And I would add to that, be humble, be open, and take opinions as valuable advice. We all have something to contribute.
I would say don't necessarily just stay within your field. Get out there, go to the multidisciplinary conferences, go talk to people, and spend time with them.
I think the best thing that our clinic has is that we have an orthotist there for an entire day in the diabetic foot clinic, so they can go back and forth between where the nurses are debriding wounds and where we are debriding wounds and casting, and anticipate what devices need to be made. And our in-house orthotist also spends a half a day just being in clinic to be available to talk to the patients, the doctors, and anticipate the needs when they're coming out of a cast or offloading device.
And Holly, can you add your thoughts to that?
Yeah, I mean, just kind of what I said earlier. I obviously, as a technician, well, in my case anyways, I don't have a lot of outside exposure. I just deal with like orthotists and prosthetists. But just the open communication and being able to have back and forth conversations and feeling comfortable enough to do that, and clinicians allowing that to happen, is super important.
Mm-hmm.
Thank you to our panelists for sharing their expertise today. We've heard about the technical side of providing devices, effective offloading techniques, and how teamwork across disciplines is essential in caring for people with diabetes. I think we have 4 questions, so I'd like to spend the next 2 to 3 minutes answering these. Panelists, if you can assist. We have a question from James Tarrant. Curious about the group's protocol about dealing with Charcot foot diagnosis. What does that treatment pathway look like? When is treatment complete? Maybe Lynn, I can pass that to you initially.
Well, certainly in our clinic, there needs to be visual swelling, redness, sometimes pain, but often no pain, and then an X-ray for a differential diagnosis and blood work to rule out infection. But many times the patients that are coming in have already been on treatment for infection that hasn't been effective. So it becomes X-ray, diagnosis of the fractures, and then treatment.
Thanks, Linda. John?
If as soon as we have a suspicion of a Charcot foot, we're going to go X-ray. It can often come back negative. We're going to go X-ray bone scan. If it's hot, even if it's radiographically normal and it's hot, and we have clinical confirmation and diagnostic confirmation of a Charcot process, especially in the early stage where it is hypervascular, we're going to immobilization immediately, and we're keeping them immobilized until we get further diagnostic studies. We will see typically a temperature differential, as Lynn spoke of before, and they're going to remain immobilized and in an immobilizing device, whether it's a removable cast walker or a Charcot restraint orthosis walker, until that temperature differential is below the 2-degree mark, exactly as Lynn has indicated.
Very good. A great follow-up question to this, probably a quick answer. If you have one, Lori Ballard, can you recommend an appropriate thermometer for measuring accurate skin temperatures for the lower extremities? John?
Yes. Canadian Tire has an excellent optical thermometer for like $35, and it's actually quite decent. Obviously, at the Foot and Wound Clinic, we have very expensive thermometers. We've tested the commercially available devices against it, and they're reasonably accurate within, say, 1/10 of or 1% accuracy of the very expensive clinical devices that we use. I strongly encourage you trying one. There's no risk in terms of the expense.
That's very helpful and accessible. Thank you, John. A second question from Lori Ballard. Would it be appropriate for certified orthotists to do the InLo diabetic foot screen? No, just moved. Oh, assessment in addition to training to complete the screen. Oh, well, sorry. Is there training needed to complete the screen?
Dr. InLo was my mentor, in fact. He's the founder of the Sheldon Schumer Foot and Wound Clinic. And I definitely would encourage use of the InLo 60-second screening tool. Linda and I included that as a part of our presentation in Fredericton last year, and we provided QR codes so that you could actually print your own diabetic screening tool, the InLo diabetic screening tool. So yes, I encourage its use. And if you need an education on it, or there's anything you're unfamiliar with, contact myself or Linda, and we'd be happy to help.
Thank you very much. We do have a couple other questions, but unfortunately, I think we're going to get cut off here shortly. So please reach out to OPC if you have a question that you would like us to explore further. Thank you all for joining. Before we depart, I challenge each of you to take one idea from today and put it into practice. Think about how you can engage more closely with your allied health partners. That's the big takeaway we want to leave with you today. Even small shifts in how we connect across disciplines can have big impacts for our patients. We encourage you to join us in celebration on September 19th as we recognize National Orthotics and Prosthetics Day and gather together for our virtual event, a chance to learn, connect, and celebrate our profession. Please visit opcanada.ca to get involved and registered. Lastly, I'd like to thank all of our panelists. This has been great. I'm so thankful for this opportunity to bring you all together under the name of OPC and National Orthotics and Prosthetics Day. Thank you to the committee for putting this on, the Canadian Podiatric Medical Association, and the Canadian Physiotherapy Association for making this event possible. A recording of this panel discussion will be made available to OPC members following today's event. Thank you again and take care.
All right.
Thank you.
Thank you.